Frances has been a psychiatrist for 30 years and she specialises in mental health, rehabilitation and psychosocial interventions. Her PhD examined the introduction of cognitive remediation and social cognition interaction and training into routine mental health care. She's the Director of Rehabilitation Services at the Metro South Addiction and Mental Health Service in Brisbane. So we're thrilled that she can come along and join us today online as part of this online symposium. Before Frances starts her presentation today, I'd like to start by just acknowledging the First Nations people as the traditional owners of the land that we are all on today as we join together around the nation for this online event. We wish to acknowledge all elders past, present and emerging. A couple of housekeeping issues from us today. First of all, everybody is on mute and Frances will be speaking live. We will be recording this so that everyone will be able to access the video link later on. If you would like to ask a question of Frances, please use the chat box that's available here on the webinar. After Frances delivers her presentation today, we will have some time for questions and answers. So we will see how many questions we can get through today. So we do encourage you to ask questions in the chat box. So Frances, it's over to you.
Lovely, thanks Hayley. All right, well look, thank you everybody for joining us today, and it's my pleasure to hopefully give you a positive slant on the progress made in understanding what we call psychosis. Just one of the things I'm going to focus on is diagnosis, and any of you who are Harry Potter fans know the Sorting Hat, and the diagnosis that we use, the DSM-5, was established to get reliability. That is, the same doctor being able to put the same label on an illness reliably between people. This is important in terms of being able to develop treatments, but it's not very important, very useful in understanding the illness syndromes that make up psychosis. So the biggest illness of the group of disorders called psychosis is the disorders that have the label of schizophrenia. There's a number of symptom domains in schizophrenia: hallucinations, delusions, what we call the positive symptoms, the negative symptoms, the withdrawal, the lack of motivation, the lack of emotional expression. The neurocognitive deficits, problems in attention, memory and recall that can be particularly functionally disabling for getting back to work or study. And the social cognitive deficits, being able to understand different social contexts, being able to understand facial affects, and being able to respond appropriately. In our current diagnostic system, it tends to favour the positive symptoms. So in DSM-5, you need 5 key symptoms of psychotic disorders, either delusions, hallucinations, disorganized speech, disorganized or catatonic behaviours, and negative symptoms. And you need to have them for a certain length of time. 2 of these 5 symptoms are required for at least 1 month, and at least 1 symptom must be one of the first three, hallucinations, delusions, and disorganized speech, the positive psychotic symptoms. There's also a mention about the level of functioning being below that of pre-morbidly, before becoming unwell. But you can see already, although this may give us a reliable picture of people suffering these symptoms, it doesn't describe all the symptom domains of people with schizophrenia. In addition, there's a real problem with diagnoses, particularly categorical diagnoses where people are put in a certain category rather than describing the dimensions of experience of psychosis. For example, that I might have an illness that's predominantly characterized by auditory hallucinations. I don't have many delusions. I may have intact cognitive functioning, but poor social cognitive deficits. So you can see a label like schizophrenia isn't very satisfactory in terms of being able to really understand the person. In addition, O'Hagan has noticed that once you get a person to accept a label, you also get them to accept behaviour which is attached to that label. That is, you're setting already an expectation of behaviour. To be called schizophrenic, an awful expression, turns you into that. Obviously, she's exaggerating to make a point, but you can see how problematic these labels are. And also, quotes from people who have been labelled, or family members who've had their loved ones labelled. They put labels like schizophrenic onto him, but it seems so superficial. They didn't get down to the depth of what it was. They looked at the mental problem instead of seeing a whole person with a mental problem. And this is a huge emphasis now in mental health, in that we need to personalise the treatment and diagnosis. That labels that we've used in the past aren't satisfactory, particularly to the person that we're trying to look after. So the current perspective is more person-centred and integrative diagnosis. So taking into consideration their social context, their values. So a person-centred approach is also collaborative, so that the clinician and the person have a shared understanding of what's wrong here, and also what we need to do. It's important for us to get people joining with us as health professionals to have a shared understanding of what the treatment goals are, a true partnership in care. So person-centred psychiatry aims to put the whole person rather than the disease at the centre of healthcare. And this is through systematic attention to the lived experience, clinical communication and social context. In some ways, we can wonder why we've never done this, why this is a modern concept. It makes so much sense. It also makes sense not only in the treatment setting, but in the social community setting. There's a big need to fight the stigma of mental illness. What they've found in Britain, when they've looked at surveys of people's attitudes, community attitudes to mental illness, is that there's some improvement in acceptability of, say, anxiety and depression, but still a huge lack of understanding about more disabling illnesses like schizophrenia. When we look at stigma, some of that is just knowledge-based, that the knowledge of people of rare disorders like schizophrenia is very slim. So they may not have ever known somebody with schizophrenia, so their knowledge base comes from extreme media and movie portrayals of psychosis. There can be attitudes, just like attitudes, hopefully, that are getting antiquated, like people with mental illness are weak. They don't have strong characters, which is just obviously untrue, and hopefully attitudes from a different era. And there's also behaviour, not in my backyard type thing. Okay, yes, I don't have a stigma against mental illness as long as they're not living next door. And so for true community social inclusion, we need to fight stigma in all of these domains. We need people to understand psychosis, to have informed attitudes that don't prejudice or bias people with psychosis, and that they are inclusive of these people into their communities and neighbourhoods. This isn't just a problem in Australia. In Korea, they've renamed schizophrenia. They thought that the label schizophrenia had too much baggage and didn't describe what people were experiencing. And their signs for schizophrenia actually mean attunement disorder, which is one that I particularly like. The Japanese, Togo Shitsuru, excuse my pronunciation, is integrative disorder. But if I had to choose, I rather like the attunement disorder. But it'll be interesting if there's any feedback of what people's favourite term is. But obviously schizophrenia is really unpopular, and perhaps the ongoing use of that label continues and perpetuates stigma that we're trying to reduce. So what's the optimal diagnosis for schizophrenia, what we currently call schizophrenia? And if I'm going to take a scientific perspective and a modern medicine perspective, then modern medicine is looking at precision medicine. And this is an approach to disease and treatment and prevention that accounts for the variability in genes, environment, and lifestyle. The ideal diagnostic system takes what we see on a superficial behavioral level down to the cellular, and we've got to develop biomarkers so that we can justify and validate the diagnosis by clear biomarkers, you know, like blood tests for some disorders. And this identifies the underlying pathophysiological profile of the individual, not a population of people with those surface level symptoms. And it can go on to inform precision prescribing of specific interventions of known effect and acceptability. Currently, our diagnostic systems are broad categories, and within a label like schizophrenia, there are a wide number of variability. So some people within the label, having the label schizophrenia, would be suitable for the therapies I run, like cognitive remediation and social cognition, integration and treatment, interaction and treatment. But other people having the same diagnosis wouldn't be suitable. So precision medicine also helps with precision treatment. So we're at a little bit of an impasse at the moment. And the impasse is that, one, the label for the most common psychotic illness, schizophrenia, is unpopular, and even as a clinician, often not as useful as you might think. But on the other hand, science hasn't got to the point that's given us a good replacement, besides perhaps changing the name like the Koreans and Japanese have done. So we don't have good biomarkers that would really make precision medicine a reality today and now. This is the direction of not only modern medicine, but modern psychiatry. So it will come, it's just not quite there yet. So what has been the progress with research? I'm a rather cup half full person when we come to this, and I hope I can share with you a sense of optimism about where we've come to, but also a sense of energy for the research and development that's needed to take the discovery forward to improve treatment and care of people with psychotic disorders. So if, again, using schizophrenia as the most common psychotic illness as an example, we know for a number of people with schizophrenia that there is a neurodevelopmental origin. That is that changes occur soon, either within utero or soon after birth, that leads to a vulnerability to these group of illnesses that we call schizophrenia. What we know in utero, that a number of general things like infections, malnutrition, hypoxia, stress, toxins, paternal age can influence the developing brain. Now, in some ways, these influences lead to a vulnerability for a number of outcomes, not just schizophrenia. Then we look at birth, and a number of people who go on to have psychosis have birth problems, either low birth weight or uterine growth retardation, IUGR, or low head circumference, problems with the labour and delivery, or congenital abnormalities. Then as the child grows up, there can be delayed in milestones like beginning to walk and talk, some neuromotor dysfunction, so they're not as coordinated, say, as their siblings, or perhaps if they're twins, their non-affected twin. And there can be social cognitive disturbances, troubles making friends, being withdrawn, and their growth rate is slower than would be expected. Adolescence is the time when we can see a transition to what we understand more as psychotic illnesses. So it can be normal in childhood and adolescence to have imaginary friends. And I was asked once by a school child who was doing a work placement, what's the difference between an imaginary friend and having hallucinations? And really, it's the persistence into adult life with associated dysfunction. So often these imaginary friends become persistent and then nasty and interfere with day-to-day functioning or achieving life goals like work or study. Also, at the time of adolescence, it is a time of risk-taking. We understand that taking risks in adolescence is a necessary part of building their own individual identity and individuating from their parents. But obviously, in children with vulnerable brains, that risk-taking can lead to problems and can lead to the manifestation of psychosis if that risk-taking involves illicit substances, particularly the hallucinogenic substances, but also cannabis. And then in adulthood, we're getting the overt symptoms, the positive symptoms, negative symptoms that we associate with the diagnosis of schizophrenia. So taking a life course perspective on schizophrenia like this gives us opportunities for primary prevention. And so this is where we look at the factors that occur early in life, both genetic and non-genetic factors that impact on the brain development and can leave a person affected to adult onset illnesses like schizophrenia. One of the things that has become very a focal point of a lot of research is epigenetics. So it's not just that you're born with a set of genes that make you vulnerable to schizophrenia, but that gene is just like, that gene sequence is just like the old pianello, or the pianos that used to have a music written and would play on their own. It has to be read, and that genetic material gets read in a way that's influenced by the environment. This makes humans highly adapted to their environment. Obviously, our environment, even from when I was a child, has changed incredibly. Probably the most incredible thing is the use of technology like we're communicating today, which wasn't around in 1959. You know, we just got black and white TV in the country town that I was in around that time. So this sort of technology we've had to adapt to. Our brains have had to change and read our genetic code in a way that is adapted to modern environment. And so the genes we are born with aren't static. It doesn't mean that we're born with an immutable set of genes. The environment can influence how that genetic code is read. And again, this is an opportunity. So what are all these opportunities for prevention of psychosis that I'm talking about? Well, the first one, if we think back to that life course of schizophrenia, the first one is optimal antenatal care of an at-risk pregnancy. And a number of maternal and child welfare services now consider people with significant illnesses, including mental illness, as at-risk pregnancies. So they ensure they have optimal antenatal care. Particularly, it's important things like stopping smoking, if at all possible, because smoking is related to smaller babies' intrauterine growth retardation. So optimal antenatal care is the earliest point that we can intervene. The other thing is in the delivery, in the labour suite, considering it as an at-risk delivery. If two parents, both with mental illness, at risk of psychosis, their risk to their child, the child does have an increased genetic risk than if they had one parent with psychotic illness. Combined with labour complications, that risk increases from about 40% to 60%. So that's a huge intervention. If you can have a good labour and delivery, you've reduced about 20% of the risk for that baby following delivery. The other big point of intervention is eradicating bullying and child trauma. These early traumas can affect the hypothalamus, particularly if they are chronic stressful life events. And we know that a lot of this behaviour, for example, childhood sexual abuse or physical abuse, occurs in the family environment over long periods of time. And eradicating bullying, which occurs usually in the school grounds when many children are at school from the ages of 5 to 17. So they've had 12 years sometimes of adverse experiences from their peers. It's also for children at risk of psychosis, so they've got these vulnerable brains, it's important to have avoidance of illicit drugs. They may point out, they may say, oh, Joe uses, you know, speed on the weekend and doesn't affect him, I'll be right. Well, no, Joe is maybe different from you. Joe may not have parents who've got a psychosis or a grandfather who's had a psychotic illness. So we're all different, and adolescents are at that difficult age where they want to be different, but they want to be the same as their peers. And so sometimes it is hard for them to avoid some of these things that they're particularly at risk of. But if at all possible, and this can be where good parenting comes into play. I've had a number of people I've looked after who've had children, and their children have grown up, gone to uni, and they have been particularly taken particular care to educate their children that they have many advantages because they've got the mum say that they've got, but also they need to consider that for them, risk-taking in the form of illicit drugs isn't wise. So these are opportunities for primary prevention of psychosis. Now let's look at brain functioning and how the brain functions when somebody experiences psychotic symptoms. Now, probably everybody has heard of the dopamine theory of psychosis, and I want to just unwrap that a little bit, explain it a little bit more. We knew that dopamine probably had something to do with psychosis from recreational drug use, for most of last century, use of amphetamines. Amphetamine releases huge amounts of dopamine and results in states that can mimic psychosis, so with hallucinations and delusions. Often, they can be time limited though, just for the time of intoxication. We know that drugs that block dopamine are often effective as antipsychotics. In the brain, dopamine is a normal neurotransmitter, and what information it transmits is to tell us what to pay attention to. So hopefully at the moment the dopamine's telling you to pay attention to me or to the slides, but it's part of our reward learning pathways. So when you're hearing novel information or learning something new, the dopamine peaks. So we know that if perhaps we've got excessive dopamine, then we start taking excessive notice of things that normally we'd ignore. So background noise that isn't important, you're wanting to focus on the talk and you're hearing a lot of background noise, then if you've got a huge amount of dopamine release, you may suddenly focus on that background noise and think it's relating to you in particular. So there we've got dopamine, abnormal dopamine release resulting in an abnormal dopamine function. So its normal function is to tell us what to attend to. And when it's functioning abnormally, when we've got too much dopamine, we fail to screen out unnecessary information, and that can lead to symptoms like hallucinations or paranoia. So we were talking before about the neurodevelopmental abnormalities. How can these things come together to cause schizophrenia? Because our current understanding is that schizophrenia is an illness that's caused by multiple genes of small effect and multiple adverse experiences over life. That it's not just one hit. You just don't get a gene called schizophrenia and develop the illness. So this is, again, an area that is cause for hope if you're a cup half full person in terms of interventions. So the genetic studies look at copy number variants, which are spontaneous mutations in the genetic code, but also developmental genes. If we understand more about the genes that are coding brain development, maybe on a genetic level, we can do more to make vulnerable brains resilient. In the developing child, these genetic events and profile combines with the pre and perinatal events that we were talking about, and in fact impact on the development of the child. So there can be these subtle motor and cognitive and social deficits, a bit clumsy, socially awkward, and then that can impact on the developing child's social interactions at school. So they may become socially anxious and depressed as young children. Then later in early adolescence, they develop these quasi-psychotic ideas. They're often fleeting, not permanent, and not functionally disabled. But then there might be a second hit. So there may be early and late social adversity, like trauma, like bullying, like drug abuse, that leads to this dopamine dysregulation and manifests as psychosis. But let's get back to the complexity of psychosis as a diagnosis. A famous researcher in the Netherlands, Jim van Os, has talked about the Salience Syndrome. And what I like about this slide, it shows the various symptom domains that people can experience. So you might have patient A with a lot of negative symptoms. They're withdrawn, socially awkward, who have a cognitive deficits, disorganized, problems with attention and motivation. And then another person, patient B, who's got the same diagnosis, but have got a different set of symptoms. So they're depressed, maybe with some mood symptoms, some periods of upward mood elevation. Some disorganization, but not as much as patient A, and some positive symptoms, particularly when they're particularly depressed or manic. And then patient C, who's got a lot of disorganization, marked positive symptoms, not so many mood symptoms, and not so many of the cognitive deficits. So currently in our diagnostic systems, all of these people may have a label of schizophrenia or another psychotic label like bipolar affective disorder. I hope it shows how if we were to treat all of those patients in the same way, we'd be not treating their particular illness well. So by understanding the various dimensions of people's experience of psychosis, we can deliver better care. So not everybody is going to respond just to an antipsychotic. Not everybody is going to respond to a mood stabilizer. And many people are going to need psychosocial interventions like the ones that I specialize in, cognitive remediation and social cognition, interaction and training. What about this vulnerability to delusions? So we've talked about these, the vulnerabilities that you might come into adulthood with, and then the stresses that you may experience. Now, it may be because of some developmental traumas or your genes, you've got attenuated resources, perhaps you've got some cognitive deficits. You might have experiences that lead to negative representation, that your concept of yourself, about the world, your confidence about positive outcomes is reduced. So you've got perhaps impaired reality testing combined with some of what we call cognitive biases. You're scared, you're overly suspicious, you're hypervigilant, and then can lead to the formation of delusions. So the young child who has a genetic vulnerability, perinatal complications early in primary school, is a socially withdrawn child with few friends, then gets bullied at school, starts believing that they're a failure, that nobody likes them, then goes away to high school. Suddenly their anxiety peaks and they feel, not only do people not like me, but they're out to hurt me. They then isolate, say, in their university accommodation. They never experience any positive interaction with other people. And that safety behavior of not interacting with others to avoid being criticized also confirms their belief, their delusion that they're under threat. And so you can see how not only the genetic vulnerabilities, the biological vulnerabilities can combine with real life experiences to lead to symptoms like paranoia. And so this is sort of the progression in adulthood that occurs. So you might have come into as a young adult with these vulnerabilities. You say leave home to go to uni, you feel isolated, you get into some perhaps destructive coping strategies like drug taking and have trouble sleeping. You start feeling socially anxious, This feeds into long-term feelings of feeling vulnerable, sensitive to rejection. You start making hasty decisions, jumping to conclusions that people don't like you without giving them a chance to get to know you. You feel odd, you feel uncomfortable when you go out. You search for meaning. Why is this so? And suddenly you get this idea, I know why it's so. I'm under threat. Nobody likes me. And so you can see the development of paranoid symptoms in vulnerable youth. These are common experiences for young adults, having to make new social contacts outside of the family. And so let's look at this social cognitive dimension of psychosis, particularly as it's not well understood. So let's pretend this is Joe. Joe's come to work with this face. We look at his face and say, I've got schizophrenia. With people with schizophrenia, they often don't scan the face well. They just take in a limited amount of the facial features. And I come to the conclusion that my co-worker is angry. Okay, jump to conclusions, but you know, it makes me feel a bit better that I made a decision of what how Joe's feeling. But then suddenly, because I feel insecure and I've got what we call a personalizing bias, Joe's angry with me. And then I don't consider any other possibilities, and I start acting in an unfriendly way towards Joe. So you can see that I haven't considered, has Joe just got a parking ticket and he's coming in a bad way? I've personalized and said it's about me, and suddenly I'm very paranoid about Joe. So in therapies like SCIT, social cognition, interaction and training, we start looking at some of these skills that are needed to read facial expressions, how to think in social situations, to ensure that we don't jump to negative conclusions that can make us vulnerable to paranoid thinking and delusional thinking. So we have come a fair way. Perhaps it depends whether you think cup half full or cup half empty. I do share the common belief that we're not there yet. We've got a long way to go. We need to combine really good research, discovery research, with research into treatments to improve the outcomes, the functional outcomes for people with psychotic illness. So our cup isn't full yet, but I think we have reasons to be optimistic, and we do need to take into account where we've come, how far we've come, and keep our energy up for future advances that hopefully are going to include a lot more collaboration. And keep in mind that psychosis is a late stage of illness like schizophrenia. So there are opportunities in the early developmental phase, opportunities in the transition to psychosis with teams like early psychosis. There are important post-illness responses that help people engage with the treating team in a meaningful partnership that's going to help them recover. And then the future hopefully will be personalizing things like medication to reduce side effect burden, and hopefully to target symptoms other than just the positive symptoms. What we do know now is that few people get comprehensive evidence-based care. Most people get antipsychotics, but they don't get the interventions that I champion, like interventions targeting functional improvement, cognition and social cognition. And there's poor integration of care elements, particularly with the mental health services and the NGO sector, and we really need to get that better. So we've got a lot of things that work, but there's a failure to integrate and implement all of those bits of treatments that work. Okay, so Comprehensive psychosis care usually involves medication in a shared decision-making way with the person, psychosocial interventions, family education and support, and illness education, often delivered by peers who've been through the illness themselves. Cognitive behavior therapy, I've shown you examples of how the brain can process social information in a way that leads to paranoia. CBT, targeted at those thinking problems, can improve and decrease the vulnerability to paranoid information processing. And cognitive remediation, particularly for the thinking skills that are encapsulated by attention, concentration, memory. And lifestyle support, helping people live in adequate accommodation. And obviously now there's a huge emphasis on no mental health without physical health. And so we've had the catchphrase, no physical health without mental health. Well, it works both ways. No use getting people their mental health better if we've led to them having metabolic syndrome, being overweight, and a reduced life expectancy because of the treatments they've received. So we need to design the services around the person rather than around the service, greater choice, greater voice and collaboration, greater accountability, and improved partnering. So the way forward will be better evidence-based interventions that are accessible by everybody who needs them, that are implemented well, and then I think we'll continue to progress, continue to fill our cup. So thank you. This is a painting that was purchased at the Schizophrenia Fellowship Annual Art Show when we used to have it in Queensland. And I think it symbolises the phases of the illness, of being chased by the illness, symbolised by the shark, and then eventually getting to the shore, getting to safety. And that's where we all need to be, safe and as well as possible. Thank you. You're on mute.
Thank you, Frances. Thank you so much for that talk. That was incredibly informative and really goes a long way to helping increase understanding about psychotic illness and fight stigma, which is what Schizophrenia Awareness Week is all about. So thank you so much. There have been quite a number of questions coming through on the chat. So thank you to everyone who's posed questions. We'll go through some of them. Time permitting, we'll get to as many as we can. So Frances, we have a question from Mary. Mary would like to know, what do you think has to happen for rudimentary changes like the kinds of questions that Centrelink asks about mental illness to help end discrimination?
Yes, and look, one of the problems is that they're trying to make forms fit everyone, and one size doesn't fit all. And so the forms for Centrelink don't encapsulate the difficulties that people with mental illness have. I can understand why they don't want multiple forms, but at the moment, the best options are to have a support person going in with the person making the application in Centrelink. But the other thing is that we doctors need to be better at writing our part of a Centrelink form as well. But I think that probably would be made better if they had simple examples. So if we worked in with Centrelink and said, not just physically unable to climb or lift 5 kilograms, you know, unable to plan out their working day, will needs assistance to organise their working day, something like that. So it's a difficult one. I use Centrelink the whole time as an example for how to deal with frustration. So, but I share your frustration with the Centrelink forms, and I think, you know, probably we need to work in with Centrelink a lot more than we do.
Mm. Yes, another example of there's a long way to go.
Mm.
So we have another question here from Christine. She's wondering, Frances, what are your thoughts on using open dialogue as individual-centred treatment?
Yes, look, I haven't had a lot of experience with open dialogue. In principle, it really does encapsulate a lot of what I was talking about, and is very popular in Victoria. I just don't have a lot of experience with it. But in our treatment guidelines, the College of Psychiatrists has updated the treatment guidelines, and we do say that this is a intervention to keep an eye on. So I think particularly in certain circumstances and for staff who are trained in it, it definitely is a possibility, particularly for person-centred and family-centred care.
Mm. Thanks, Frances. We have another one from Mary. She's wondering, does paternal age relate to men as well as to women when we're speaking about the life course perspective?
Yes, and keep in mind this has been done by, this research is done by epidemiologists, and epidemiologists take a helicopter view, and they're trying to find patterns in the population that might help us understand illness. And so what they found is that there is a small increase in risk when the father is older, and you know, it is nice that fathers get blamed for at least something. You know, it always seems to be the mother, but it is true. But keep in mind, this risk is very small. It's one of the small risks that, you know, can add. So our youngest daughter says, so Dad, that means that if you'd had me when you were younger, I'd be smarter. And, you know, maybe not. So, but there is something in the longer, as we age, there's more opportunities for these spontaneous mutations, these copy number variants. And so there is a small increase in risk. But again, I wouldn't, it's important that people don't get too anxious about epidemiology research. It very much is a population just trying to look at what might be novel links into the parts of the illness we don't understand now.
Yeah, cool, great. Okay, oh, there's so many questions coming through. Thanks, everybody. So there's another one here. What innovations are there in regulation of sleep in schizophrenia?
Yes, sleep's very interesting, and it's getting a lot of attention at the moment. We've been particularly interested in sleep in the mood disorders, particularly bipolar affective disorders. There's a couple of things that we're concerned about in schizophrenia. One is obstructive sleep apnea, contributing to some of the negative symptoms like fatigue. That's where people stop breathing for brief period during the night and need a CPAP machine. But the other thing is that these sleep, as terms of risk of, and probably as a stressor, sleep deprivation can be particularly bad. And so having good sleep hygiene is really important. So it is an area of research. It's not my area of research, but at the moment, probably the best thing we can do is, particularly for people who are suffering a lot of fatigue, to perhaps having a sleep study done, but also for the rest of us having good sleep routines can really help, because sleep sleep deprivation is used as a form of torture, and that's for a reason. Any of you who've been a young parent and sleep deprived when your children are young know how it does mess with your mental health. So very important area.
Definitely. So we have one here. Leslie is wondering if cognitive therapy can be incorporated into day outpatient programs, which is currently missing in the public health sector, as an alternative to hospitalisation.
Yes, and look, we do need to get more access to CBT for psychosis. Our service is trying to develop that, a system of referral and meeting the demands of people who may require that. I've done that really, CBT for psychosis, since about 2002, and it does give people skills to avoid hospitalisation, because that once they've gone through a course of CBT, they can use those skills to manage stress, manage their distress, before it gets to a point of hospitalisation. So the real issue is how to meet the demand, and we really need a lot more. In UK, the guidelines for schizophrenia say that everybody diagnosed with a psychotic illness should have 16 sessions of CBT. There was such huge waiting lists for that, though. You can see that even where you mandate that people should get CBT, there's a real issue in how we deliver it. So that's an area that where people like myself, it's a challenge that we're taking on. I'm not a neuroscientist. I can't take on that area of research, but offering CBT to those who need it is really important. In my basis of my PhD, we disseminated one form of CBT, which is the social cognition one, all through Brisbane, and as sort of a bit of the wash of my PhD, those programs and training is now available all through Queensland, the major centres in Queensland. But it does take a lot of investment and commitment to implement those sort of psychosocial interventions. Mm. But that's the challenge. You've got to check how I'm going in a few years' time.
Sounds good. So we have another question here for you, Frances, about whether these strategies for optimal care are being communicated to the NDIS, the NDIA, when it comes to plans for people with psychosocial disability. What's your take on that?
Yes, and I'm involved with the Australian branch of the World Association of Psychiatric Research, and so a lady on that committee is very much involved in the NDIS. She's an academic, Lisa Brophy from Melbourne. And I think there's two. One, the NDIS was a bit slow, an NDIA, in understanding the needs of people with psychosocial disability. So we have been doing a bit of catch up. And then the issue has been actually skilling up the workforce to write good reports. It's a different way of viewing things. And even, I'm a psychiatrist who's into rehabilitation, but even I get my reports checked out by our occupational therapists, who are a bit more attuned to the type of language that the NDIS and NDIA want. So at the moment, my understanding is there's more available for the psychosocial packages than have been given out. So we really need to get on and make sure everybody who needs them are accessing the packages. I've had very good, lot of the people of my patients who've had the NDIS packages, it's been a really wonderful collaboration, and not everyone has had packages that have worked, but I think it's a major advance that if we can make it work, then would be really wonderful.
Thanks, Frances. So I think we've got a few more minutes left, so we might only have time for one or two more questions. So there's an interesting question here from Marie. She's wondering, is there a plan to raise awareness of the importance of the role of the carer in enabling the consumer to get the care and treatment that they need? So she's explained that she does care for someone with schizoaffective disorder, and she's finding the role challenging because members of the mental health profession tend to dislike carers or advocates. So Frances, what's your take on that?
Yeah, look, I think we could do a lot better. We're actually considering in my service the advantages of what we've found with COVID, reaching out to people, using modern media to meet the need, because we're not flexible enough. And so we're hoping that by using modern technology that's been introduced since COVID, that we'll be able to support people. One of the things, and I don't know if Marie wants to comment about this, I think there's been an overemphasis just on psychoeducation without giving carers the skills, not even asking what skills would you like, you know, what supports could we work together with NDIS to help you to deliver the care that you're delivering. So I think there's huge opportunities, and we've probably all got to be really humble and just realize that if we work together, we can solve these things. But I think the real mistake is not including the carers. There's been concern about, you know, issues of confidentiality. It's very rare if you say to somebody, look, yeah, your mum would like to have some information. What do you want me to tell mum? And we work collaboratively on that. Most parents don't want the most intimate detail of what's being discussed in the meeting, but they do want enough for them to know, how can I help? How can I not make things worse? And so I think there are moves afoot to try and improve the support to carers, but getting that balance right has been usually a bit of a problem. So I hope we do better in the future, Marie. Yeah.
Thanks, Frances. All right, everybody. Well, we've hit 2 o'clock. So I would just like to wrap up by saying a huge thank you to Frances for coming online today and delivering her online presentation on psychosis to us all. And thank you to everybody who's been involved. We had 80 participants joining us today for this session, and thank you to everybody who asked questions. Our apologies if we didn't get to all of those questions today. We did miss a few there. So yeah, we thank you so much for your participation, and we look forward to doing this again soon, hopefully next year.
Thank you all.
Thanks, everybody.
Bye.
Bye.